Hey everyone, thanks for joining us. I'm Samantha and this is transirl. So we are holding on for just a moment here while our guest gets dialed in this afternoon, but I wanted to talk a little bit about what our guest this week focuses on, and that's gender affirming surgeries. And what's really unique about this guest is that this is actually a guest who I've worked with before in my own transition. So Marci was actually the doctor that I went to for GCS. And there's a great picture of the two of us there. And let's see, my surgery with her was March of 2018. And, it's such an interesting experience to go through this, just transition by itself. But to have this affirming surgery done is really something else. And, ooh, here we go. What's really important when anyone's considering surgery is that they really are comfortable with the surgeon who they end up going with. And so that's something we're going to be talking about here tonight, of course, as well, is being comfortable with the surgeons that we're working with, and what are the right questions we're going to ask those surgeons as we're working to schedule these procedures. So let's go ahead and get into it here tonight. We have a wonderful guest tonight. I want to get to as many viewer questions as possible. So Stephen will be monitoring the live chats on YouTube, Facebook, and Twitch. So if you have any questions for our guest, please make sure to submit them there. 3 quick notes, though, before we get started tonight. We are talking about surgeries related to transition. I know that might be a difficult topic for some people to listen to or talk about, so please be aware if that's something that you're sensitive about. Number 2, our guest is joining us today without compensation, and no one with our show has been compensated by our guest. This conversation is presented as a casual conversation, not as medical advice or as a recommendation of any provider over others. And number 3, gender-affirming surgeries are not a requirement of transition. Each journey is unique, and no one is more or less valid than anyone else because of want of, access to, or completion of surgical procedures. So with that, I think we're ready to roll here. Our guest tonight is a world-renowned surgeon and someone who has provided and advanced gender-affirming surgeries for more than 17 years. She is on the board of directors for WPATH and has previously served similar roles for GLAAD and the Transgender Law Center. You may have seen her recently speaking with Katie Couric in her Discovering Gender special during an episode of I Am Jazz, or any of her other numerous media appearances, as she remains one of the most visible surgeons providing affirming surgeries for transgender patients. With that, I'd like to welcome to the show Dr. Marci Bowers. Welcome, Dr. Bowers.
Hi, Samantha. How are you?
I'm doing well. It's so good to see you again. It's always nice to see you when I'm not like on an examination table. I think that's a nice change of pace.
Well,
we should do this more often.
Off the table. Come on now.
Thank you so much for joining us here tonight.
Thank you very much.
As do you. I wanted to give you a few moments here just to share a little bit about your background, your story, where you grew up and where you went to school.
Well, I'm a Midwesterner, so I was born in a Chicago suburb called Oak Park, and it's near Chicago, and spent 4 years there, grew up, then we moved to Wisconsin, so I picked up a little accent there. Some people can hear it, some people can't. I've lived in the West most of my adult life, though, and so after attending the University of Wisconsin, I went to Minnesota, eventually went to medical school there, residency in Seattle, University of Washington, and I bounced around a few places. But my most significant stops were in Trinidad, which at the time was known as the sex change capital of the world. And that's where I really perhaps performed the most important jump in trans affirming care, because it allowed me to make a link with someone from the past, Stanley Biber, who had done somewhere in the neighborhood of 5,000 gender affirming surgeries over his many years of service. And at the time, he was 80 years old when I joined him. So it was a big jump to be able to keep that link going so that future generations could benefit from his knowledge.
And I think that's is such an amazing link to the history of just the history of being transgender. Dr. Bieber was really one of the first people worldwide who stepped up and started offering these procedures. And I've read a little bit about him, but I am curious. He seems like a real character to me. I'm just curious about your interactions with him and what it was like training under him.
Yeah, he was a character. He really was. He was short. He was about 5'5" or so, but he always wore a 10-gallon hat because he was also a rancher. Even though his parents wanted him to be either a pianist or a rabbi, growing up in Iowa. So he had kind of an unlikely past as well. But it gave him a lot of swagger, and he would go out and feed the cattle each day. He actually, when he died in 2006, he actually was on a cattle drive to Nebraska when he got pneumonia. So, yeah, interesting
That's
guy.
unbelievable. Yeah.
Yeah.
But, he brought peace to so many individuals who are looking for somebody to care for them in a time where there just weren't a lot of options. In the US, worldwide, there weren't a lot of options outside of, at the time, when he started in the late 60s, early 70s, you were either going to Trinidad or you're going to Casablanca, I think. I don't know if anyone else was actually doing procedures at that point.
There weren't many. There were about 4 or 5. There was Dr. Fertrell in Pittsburgh and Dr. Seguiers in Belgium. There were a few others scattered, but he came to prominence because in the 1960s it was kind of anything goes. People had lots of options around. Because it was very much we were really much more progressive in our thinking in the way of not being politically dragged down by I don't know, I guess I would call it body guilt, or something, gender guilt, that people weren't, there was not politicization of gender until the 1970s, 1980s. But in fact, in the 1960s, you get sex changes which is what they were called, in Chattanooga, Tennessee, in Norfolk, Virginia, in Galveston, Texas. There were really a lot of locations. They were all more or less predicated, though, on the work that Dr. Baru had done in Casablanca. They were doing some sort of prototype of that. So what happened in 1971 is that Paul McHugh, who's still around, was a psychiatrist hired by Johns Hopkins. He published a paper saying that people were no happier after surgery than they were before, which of course has been disproven many, many times since then. But the effect of that paper was to close all the gender clinics, and so Dr. Bieber had to rise to prominence after that.
Yeah, that was a devastating article. Johns Hopkins, of course, closed their program down after that was written, and a lot of people lost access to a lot of those options outside of Dr. Bieber in Trinidad.
That's right.
I did want to talk a little bit.
So anyway, so he picked up the mantle and then went on to be featured in Jeopardy as the question to the answer, sex change capital of the world, and many other notorieties like Geraldo Rivera flying over, passing out in the OR in Trinidad, and helicopters flying over Trinidad when it was rumored that Michael Jackson was going to have a sex change and things like that. Yeah.
Trinidad's a unique place. I've had a chance to go through there a couple times, and I've actually been to the old office there in town, and
yes.
It's a cute little town. It really is. It's very non-assuming. It's a kind of a mountain town, mining town. It's the last place that you'd expect to see that happen, but he really did wonderful work out there, and it's amazing that you had that opportunity to train with him and then take over that practice as well.
Yeah, he had looked for someone to take over for years, and many had come through, actually, a number of surgeons, but he never felt comfortable handing the knife to someone. And so on the morning of in June, when he handed it to me, I swear to God, you could hear a pin drop all the way to Denver. It was really a huge moment. Just people literally gasped in the OR.
Oh my gosh.
So
But before
um,
you met Dr. Biber, you had an amazing career in the Seattle area, doing work up there. So it's not that you walked in the door and started training. You already had a very well established career there.
right, Samantha. I was an obstetrician gynecologist as well, but of course in my practice divided between OB and GYN, I was also known as a very good pelvic surgeon. So that was where I learned the anatomy and a lot of the surgical tricks and expertise to be able to take on something as large as vaginoplasty. But delivering babies was it seems like it might have been a distraction, but I really loved the 20 years I did of it.
I like that you say distraction there. You mentioned something in your TEDx talk that you did a few years ago about a point of actualization, a point of realization where you have to finally accept something that you've been struggling with your life. And distractions are a big part of hiding those feelings. But I mean, you yourself transitioned, and what I'm curious about is, with your career and this very prominent career, what concerns did you have before coming out?
Well, I had 3 young children at the time of my transition. My son was just a year old when I began living in my desired gender role fully, coming out at work as an OBGYN. So I had concerns of my kids, my spouse, who we still have an interesting modern family kind of marriage, and then of course my patients too. And really it was hard on everyone, although probably least hard on my kids. They were just 1, 4, and 5 years old, so they were really they were great. They never, for example, my kids never have made a pronoun mistake ever. It's really hard to believe.
And that's something we both share in common, having young kids when we transitioned. When I started transitioning, my youngest wasn't even a year old yet. They were 3, 5, and 7 for the older 3. And they've been wonderful as part of my transition. And honestly, my kids are my rock. And much the same as you, for my oldest son, once we explained it to him what was happening, I don't think he's ever gotten a pronoun wrong. And to him and
No.
to the rest of the boys, I'm mama to them. And they do wonderfully well. But I do wonder, your kids are a little bit older than mine are now. How was that for them growing up, and how are they today with everything?
Oh, there's never ever been an issue with that. I think a lot of that has to do with my spouse, who um, has been really very, very supportive all the way along, and has remained part of our lives, or my life. And so the kids it's just reality. It's just how they go along. Yeah, I think it was hard at the father-daughter dance and my daughter's graduation from grade school, but she took my son, so he played daddy.
Okay.
But they've never, they've always referred to me as their mom. So
And I think a lot of people experience that, which is wonderful, and it's great to have the support of kids through transition. You did transition. I don't have the exact year in front of me, but it was what year
1998.
about was
Oh,
that? 1998.
1998.
Okay,
Yeah.
so what I'm interested in too, just from a historical standpoint, you transitioned in the late '90s. You're continuing your work with the transgender community. What changes have you seen in how the trans community is perceived, and how the coming out and transition process works in the time that you've been active?
Well, it's amazing. There's been a number of things that have really, really changed. I think the most significant as far as patients go are that they come now with support. So they have family with them almost invariably, a friend, a relative, somebody who's there. And it makes such a difference in going through the process that you've got someone just to share time with. So that has been a big difference. But also the growth of the surgical programs as well. Seems like this is the new, the avant-garde, the trendy thing that surgeons want to get into. But that comes not just with a matter of surgical curiosity and as a business, which I worry about, but also the true growth of interest in gender affirming care and recognizing that gender is just another part of diversity and that we're really on a planet that we all share, just like viral illnesses. You know, we are all interconnected, and no longer is gender just seen as a black and white issue. We're beginning to unravel some of the misconceptions and dogma that have held our planet back from really being embracing and loving. So I think it's, I see a lot of optimism about it. When I realized that trans surgery was really a big thing, somebody said, "When do you think it was really accepted and really was on the map?" And I said, "Well, it's when the University of Kansas came to me and asked me to start a program." That was a big moment.
Well, I wanted to talk to you about that as well. You've worked with many universities, many medical centers.
Oh, I'm so sorry. Sure.
And building these new programs up. And why is that an important focus for you in your career?
Well, it was clear very early on that I was going to be a very busy surgeon, and so fortunately, I was able to live up to that and got people through it for the most part very well, and got a reputation that was solid enough that people really embraced the work we were doing and flocked to me for surgery. But I realized very quickly, too, that there was a wide range of surgical quality that was going on, and especially amongst new physicians, there was clearly a demand. People shouldn't have to travel across the country to go to a foreign city, somewhere where they don't have support, just to have gender-affirming care. So I realized that there did need to be more surgeons, regional at first, and eventually as commonplace as getting a hysterectomy or getting a gallbladder operation or whatever. The problem is that is that this is such a difficult surgery to do that even with good training, it just takes really a special combination of things. Dr. Bowers, when he was asked why he chose me, and as opposed to other surgeons, he said that some didn't have the hands, some didn't have the courage, and some didn't have the heart. And Marci was the first one to have all three. So it's not just that I was trans, but it was really all this that courage part of it. It can't be underestimated. The hands, really, that is a quality that really you can't teach that. And of course, the heart. You really have to love this population, and you have to really genuinely like working with people.
And that's such a beautiful statement by Dr. Bowers there. I am curious too, as you originally took over his practice and made it your own, what have the advances in techniques looked like over the last 17 years here for both trans-feminine and trans-masculine procedures that you perform?
Well, I don't perform phalloplasty still, but I do perform metoidioplasty, which translation is literally becoming male. So we use endogenous tissues that are enlarged with hormones to create male structures in the vulvar area. That surgery and phalloplasty have advanced a bit. There's more surgeons, certainly. It's still probably not where it needs to be, in my opinion. So I'm looking forward to seeing advances in tissue transplantation, tissue in vitro tissue growth. What do you call it? Tissue, so newer techniques that are going to advance the field. They're growing penises and vaginas now in laboratories, so that kind of thing. That's perhaps the second wave of where things will go. But in male to female surgeries, there have been a lot of improvements, and especially in recognizing that we really anatomically we're all in a continuum. So we all start out with female anatomy, and then there are a series of changes that happen through hormones and other signals that cause female genitalia to masculinize. The labia fuse, for example, and the gonads, instead of remaining in the body cavity, drop down and become testicles. But functionally, they're very similar. And so reversing that process and recognizing that anatomy really and embryology tells us how that should be done, that has really helped add to the realism for the male-female cases. Yeah. And then there are new techniques like peritoneal grafting that we're doing in New York. There's peritoneal pull-through. There are also some new methods of getting thinner autologous skin grafts that we can use now where people are lacking skin. A lot of these challenges have been forced upon us by the kids who are transitioning in childhood, where they're coming to adulthood then and looking for an adult genitalia, but we've got infantile tissues to work with. So there's a lot happening now that is improving.
Right. One thing I wanted to get from you in your own words is, when you set out to perform any of these procedures, what is your goal? And what do you think is the goal of all gender-affirming surgeries?
Well, I think you have to match people's expectations with reality. And, the surgeries, I think all too often, sometimes surgeons, they make surgeries fit their needs and not the needs of the patients. And I guess if there's one thing I'm good at, it's listening to people and trying to really trying to get to know them in a way that hopefully I did that with you. But getting to you really want people's expectations to be met or exceeded. And there are complications that can happen in any of these surgeries, but I think with prepared with enough realism about what you're getting into, people come out of it and still do really, really well. But I think
you brought up, of course, my procedure that I had with you, and I looked at multiple surgeons before deciding who I was going to go with. And there's some horrible pictures of me walking around Mills Peninsula with after surgery here. Look at that, huh?
Adorable. Come on.
Yeah,
you're adorable.
That's the kind of picture I want to share to the entire world right there. Bag and all. But no, I talked to multiple surgeons before I finally decided on you. And part of that was the rapport that we had and your ability to take what I was trying to describe and then turn that into a final result. And I'm very happy with the work that was done. I think it's, of course, it's a very personal decision where anyone ends up having these procedures done. But it's important to have that relationship with a surgeon, have a surgeon who's willing to listen to you before and after a procedure.
Yeah, I think that's true. And the other side that I have always really emphasized is that it is as much art as it is science, this particular surgery. It's not just like having a toe amputated or having a, a gallbladder operation or something. You want it. This is pretty, and this is a beautiful area of the body, and so it should at least have a reflection of that in what's offered. It's amazing how people, I'll speak of surgeons, don't really take pride in the incision. It's just such a simple thing, but that's what the patient sees. And from the time I was an obstetrician, sewing up an episiotomy, nobody would see that, but it really, from the word go, that was always very prideful of me to make things look as good as I could possibly make them look.
And a lot of that is why I ended up choosing you as my surgeon. I did want to allow you a chance to talk a little bit about projects you're working on outside of transgender surgeries as well. I know that you actually spend a significant amount of your time supporting those who require reconstructive procedures.
Yeah. Yeah, so amongst the many teaching opportunities I've gotten, besides starting transgender surgical programs in Israel and New York and Denver and Toronto and things, somewhere along the line I was asked to consider working with women who had been victims. I'll say victims, but it's actually survivors of a ritual practice called female genital mutilation. Now more less judgmentally called female genital cutting, and although it is mutilation, I think that's a pejorative term. So, but it's basically young girls that are held down against their will, but often with parents or aunts complicit in the administration of this procedure, done not for religious reasons, but just out of tradition. And parts of the vulva are excised with no anesthetic, forcibly, often violently, with people holding down each limb, and the girls writhing in pain, as young as 6 months of age, but generally in the childhood years, and leaving them without any sexual feeling, because the clitoris and parts of the labia are often removed when this is done. And that's the goal, is to take their sexuality away. And it really stands as a violation of human rights. So when I saw that, and the parallel that it had with transgender surgery, and that we're talking gender is also a right, I believe, it was a very easy match for me to say, sure, that my skills would apply very well to doing a reconstruction where we can bring back sensation.
And I think that's such an amazing teaching experience that you offer for surgeons in the area. You're over there performing these procedures, but you're also helping surgeons in Africa, in sub-Saharan Africa, perform these on their own so that they can continue to that work in your absence, as you're not able to spend, your entire year over there.
That's right. Because just like in gender affirming surgeries, I'm only one person, so I can only do a limited number of surgeries per day. And if I'm in Africa, I can only do a limited number of surgeries per day. So, but when you teach another surgeon, you build capacity, and that surgeon can teach others as well. And therefore, then you really mushroom the cause, and you allow people greater access. So that's the goal of all of these teaching endeavors.
I think that segues really well into my last question before we get to our viewer questions here tonight. In your career, you've completed thousands of surgeries that allow trans men and women match their bodies to their minds. What does that mean to you? What does that? how do you see your legacy in the community that you've helped so much?
Well, it's kind of you to to suggest I've got a legacy. I hope so. I think so. I mean, it's enormous. You know, it really is enormous. I know, and I guess that does give me a bit. You know, I used to minimize the fact that I was trans or that I went through a trans experience, because you know, I didn't want to have a competitive advantage. I wanted to be, you know, seen as an equal and be judged on the basis of the quality of the work I did. Not that I had some unfair advantage that because I was trans and people were coming to me for that reason. But it does give a special a special ability to empathize with people in recognizing that their struggle is a struggle that I had as well. And so it gives extra heart to what we're trying to do. Yeah.
Oh, I think that's a great answer. I did want to get to our viewer questions, so I wanted to start with the questions that were submitted earlier this week on Instagram, but if you are watching live, you can submit questions on YouTube or Facebook or Twitch. But let's go ahead and get over to the first viewer question we have here, and that is, once someone decides on GCS, what individual preparation is needed before surgery?
Well, that's a great common question and very practical. You know, you really have to get things in line. Most of the surgeons now that have good results will have a significant waiting list. So fortunately, there's a lot more time now than there used to be. But I would caution people that when they are deciding on a surgeon, you know, if that surgeon has a very short waiting list, unless they're very new in the block, they're probably going to have a lengthy waiting list if they're any good. So if they can get you in a month, that's probably not a good sign. So this means a wait of at least a year and sometimes multiple years. But you need to prepare, and you need to get yourself in the best physical shape that you can. You need to make sure that your reasons for having surgery are solid, and ask yourself those things, because surgeons tend to do surgery when they're asked to do surgery, and they don't necessarily drill down with you and try to make sure that what you get is what you want. Find out the reasons you want to have surgery, and really look honestly about what that's going to mean and how that might look for you. Obviously, it's like having a baby. You know, you never know what kind of parent you're going to be until you actually have the baby in front of you. But you know, babies, all you have to do is love. Babies, just, you know, that's the easiest thing in the world. And in a way, surgery is too. I mean, once you get through it, really, the nice thing is that people usually look back and they really don't know how they ever did things any other way. I guess that's what I would describe it as.
Absolutely. Yeah, I agree.
How did I ever pee? You know, what was that all about? So,
No, it's really amazing.
How do you walk with that thing?
Right? Exactly. It feels, you feel complete, and I think that's a common experience I hear from a lot of other people who've undergone surgery. And it's hard to even imagine what it was like before, after everything's all said and done.
That's right. But there are other things too to prepare. So there's a medical side, and there's the psychological side, which still is in play. It's becoming de-emphasized that we need these letters of recommendation and that sort of thing. There's also hair clearing that it is necessary in the genital area, at least for male to female surgery, and also for female to male surgery as well. If you have a hairy arm and you're having a phalloplasty, you've got to have hair cleared in that area as well. So our website, marcibowers.com, has a lot of things on it that are very helpful, that can help then get you ready for the timetable that you might need to follow. And I think there's a number of other self-help books as well that are good about that. I'm actually editing a book right now that Linda Gromko writes. So, yeah.
Very good. Our next question here from the Instagram queue is, do you have any information about the rate of complications during or a result of GCS? There
is information published. We published data on 500 some patients that underwent gender affirming vaginoplasty between I want to say 2012 and 2016, and that was published in the Journal of Urology a year ago. Thomas Gaither, Gaither, it does that, and it's a very objective look at our surgical results. But the fortunate thing about gender affirming vaginoplasty, anyway, I won't speak for the female to male surgeries, which have higher complications. The male to female operations really don't have many major complications. So you don't have to worry about big things like, heart attacks and blood clots. Surgical complications themselves, infection, bleeding, they're just not that common. They're usually nuisance type things, and those are fairly common. So if you actually look at an overall rate, I think you could say that at least 10% of patients will have some degree of tissue sloughing or granulation tissue or areas that don't heal well. But big complications, like you hear fistulas and things like that, those should be a very, very rare event for the most part. Difficulty with orgasm, I mean, those, even there, our populations, more than 90% were able to orgasm. It's generally pretty good news. Able to have sex, dilating is difficult, not always that much fun. Some people really find it painful, really find it difficult. But in general, it's a pretty workable surgery.
Yeah, definitely a reminder to stay on top of your dilation schedule for everyone out there who's slacking on it right now. You got to stay on top of it. For me, dilation isn't so much painful. It's boring. That's the real way of looking at it. It takes up a lot of time early when you're first coming out of surgery. You've got to put the time in. You need to get that time in, but you get very good at scrolling on phones, I guess, while you're dilating, or at least I did.
Yeah, thank God for my day. They didn't really have smartphones, so I don't know what I did. I'm not sure. Who knows? I think I remember staring at the ceiling a lot.
All right. Next question here. We talked a little bit about this earlier. What are your thoughts on the peritoneal pull-through vaginoplasty method that's now being offered?
I think it's a little gimmicky myself. I do think it's intriguing in that you're bringing live tissue with blood supply through, but it doesn't. The idea is that there would be a mucosal surface that could produce lubrication that could add and make vaginas better. But the bottom line is that the traditional methods of inversion vaginoplasty plus grafting have come a long way, and they really, really work well. Plus, that lining, not peritoneum, that lining, the penile skin and the scrotal skin, are cell-wise exactly what a cisgender vagina is. And so my concern about the peritoneal pull-throughs is that they don't adopt, they don't change, they don't undergo metaplasia to become the vaginas that they're meant to become. And I think our vaginas, you can't really, when you biopsy them, there's actually some studies that show that what the pathologist will read is normal vagina. I mean, it's that convincing even to a pathologist. So, trying to build a better mousetrap, while it always sounds good, it ignores things like how is the physiology of the vagina? And then the other important question is, what does it look like on the outside? What am I going to stand up and look at in the mirror every day? So, I think it's always tempting to throw the baby out with, to grab something new, but it really ultimately comes down with the quality of the surgeon. Again, in New York, we're doing the peritoneal grafting, but we're taking a graft from inside the abdomen, and then we're laying that down as we did for jazz, for example. And that works very, very well, but really I typically reserve that for someone who we're doing a revision on, or we're trying to get additional depth. So I don't like the peritoneal method as a primary vaginoplasty procedure.
I think that's a well thought out answer there. I appreciate your input and your take on that.
Sure.
Our next question from Instagram: when choosing a surgeon, what are the most important questions that we should be asking? We talked a little bit about this already, but what questions do you like to hear from patients when they come see you?
I think just that they understand what their expectations are. Why are you having vaginoplasty surgery? What does that mean to you, and how do you see your life going forward? But in trying to sort through the many surgeons now that are out there, again, their online reputations are important a bit, although those can be whitewashed, they can be skewed, there's can be unhappy patients that are unfairly judgmental about one surgeon or another. Talking to another patient is really useful, and I don't think there's anything more helpful than seeing an actual result. If somebody's willing to share their intimate details with you, it really makes a difference. There used to be a lot more sites out there that would put frank graphic photos online. Our site does that. We open the legs fully up and we show what's there. So we want to show you. Obviously, we're putting our better results there, our best results, but even our worst results, I think we'd put up against some of the ones that I see coming out now that are coming from places that didn't necessarily, didn't have the artistry behind it.
And that's so important, especially when you're in the market and you are thinking or considering surgeons. Being able to see results from surgeons gives you a general idea of what that surgeon is accomplishing, at least if they're being honest and they're sharing a good distribution of the results they're seeing. And you do have quite a few results up on your website that people can see. And I think that's very important.
Yeah, there are some that say that their hospital won't allow them to, which is not true. Some people aren't really very forthcoming about what they have, and if they aren't, you should consider seeing somebody else. Get another opinion.
Definitely. Opinions are always good, especially with any gender confirmation surgeries. There is not a more important time that the old adage, measure twice, cut once, comes into play. So be sure, be confident, and you have to be your own best advocate when it comes to any surgery, any procedure. You need to protect yourself.
Yeah, you do, and there is enough time now. It may cost you a little bit in terms of travel and money, but I think it's worth meeting with at least a couple of surgeons before you decide. Yeah.
All right, let's move on to our next question. How old is too old to consider GCS?
How old is too old? Well, let's see. Our oldest was 76. Actually, we've had two of them that were 76. I've heard of someone 77, and we talked to someone once who was 80. I think if somebody is healthy and they come
audio?
in...
I lost audio.
Do you have audio from me? Nope. No?
Oh,
okay, I'm right.
I didn't hear your response there. Can you
I said,
say that again?
I said we've had patients who were in their 70s, dozens actually, and if basically our rule is if you come in healthy, you're going to go out healthy. So I think no age is really too old. I do think I think you have to question what the reasons are. If you're waiting until 87 to have vaginoplasty, what's the point? Really, in some ways. But that's a personal decision, and the answers I always get from older individuals having these procedures are that I wanted to die a woman, and they felt like that symbol of masculinity, the penis, needed not to be there. Now, I do think I always raise questions again with people. What is your goal? I mean, nobody in public sees what your genitals look like, for the most part. I mean, Most people don't see your genitals. So, what is the need to have that? But again, you're the one standing in front of the mirror. So if it's that important to you and you need that to complete your life, we're going to do it safely. Yeah.
All right. Next question. How much of a concern is atrophy in adults when trying to achieve adequate depth?
Atrophy in adults, well, we rely on the skin that you have in the area to get the depth that we need, which we usually consider to be about between 15 and 20 centimeters, which is roughly 6.5 inches, something like that. So, but again, if your needs are that you don't need a deep vagina, if your only interest is with other women, there are lots of factors that can go into why somebody might not want that kind of depth. But if you're interested in depth, then you definitely do need enough skin to work with. And although the penile skin and the scrotal skin are really additive, so with the two of those, usually there's more than enough to work with. But from additional techniques that we've enhanced over the last few years, we can also use skin from the lower abdomen or from the groin region. So there's almost never are we limited by skin anymore.
All right. Last question that I had from the Instagram crew was, are there options to work with you through Medicare?
We've been working with Medicare. Actually, we were one of the first to submit claims to Medicare. Our first two, I think it was 20. Let's see, the Medicare limitation was lifted, I believe, in 2016, and we had a couple of patients that summer, and I know famously we were paid 1 cent on one of our vaginoplasty cases. So it's frustrating, but we're much better off if we have a Medicaid plan where we can do a single case agreement. I think in the Medicare patients, what we've done is we've asked for secondary insurance if they can possibly use that. We're still willing to submit to Medicare, but officially we're not a Medicare provider per se. We've had too frustrating an experience to date to push that through.
All right.
Sorry about that.
Yeah, I don't think that's unique to your practice either. I think a lot of surgeons are struggling with that right now.
Yeah. You just can't afford to do it for $200 or 1 cent, certainly.
No, that's outrageous. All right, now we're turning our attention over to the live chat questions here. So let's go ahead and pull the first one up. Can you help with active military? And just active military in general. As we know, with the military, the transgender ban that's currently in place there, are you doing anything to help those who are active or veterans?
I didn't serve, but I have a great deal of respect for those who have and who continue to serve. I know Christine McGinn does some pro bono work for active military, which is amazing. She'll work on somebody without insurance or without if they're active military. We aren't currently doing anything in that regard. It's no disrespect to the military, but it isn't something that we've really been approached with. I think on an individual basis, we probably would be interested in. We could probably work something out, if not a significant discount or something. But we aren't technically. We don't have a program. I know Christine does, which is amazing. She was in the military. I tend to be a little bit of a pacifist, and so I'm not to say that military service isn't important and that our defense is an important point, but I think the military has diverted an awful lot of resources from this country that could be put to better good.
Yeah, you're not going to get any arguments with me there. Let's look at our next online question here tonight. I had a no-depth GRS in late 2018. Would it be very difficult to have a revision surgery that creates a vaginal canal?
Wow, that's really disturbing. There's a surgeon that kind of, I think again, this is one of those, one of the rise of this type of procedure, zero depth vaginoplasty, where it was a function more of the surgeon being uncomfortable with being able to perform the difficult portions of the procedure rather than listening to patients about what they really wanted. And I hear this very story all too often, where they are basically talked into it and scared by the surgeon, saying, well, it's like saying, well, if you do this, your house could burn down, your dog could run away, and your wife could die. If you have that, if somebody tells you that, are you going to go forward? Probably not. So the same thing, if they fill you with scare stories about what could happen in vaginoplasty, then you might opt for something that you really don't want. So I think this is a cautionary tale as much as anything. But can anything be done? Absolutely. We can use traditional methods of grafting from the lower abdomen. This is where the peritoneal pull through or the peritoneal grafting can be very, very useful. And we can also do. There are also new autologous skin grafts. There's a number of them, Dermapure and Repliform and Alloderm too. These are also sources of potential vaginal material that can be used to line a new cavity. The good news is, because it was a zero depth in the beginning, that dissection will be virginal in a sense that there's no scar tissue in there. We should be able to find the same anatomic locations, and then it's just a matter of getting a graft to line that area. So I would not be discouraged if that's really something that you want.
And that's exciting news there. All right, our next question online. Is there a concern around having an orchiectomy first in regards to loss of skin?
I know this is a popular tale that's told out there that if you have an orchiectomy, that the skin is going to shrink and then you won't have enough. But again, it's not like the tissue is being removed, so the scrotal skin will be there and it will be available as a graft. Plus, if you're a surgeon with any wherewithal, you're going to be able to use additional skin, extending the incisions into the groin or whatever we need to do to get additional skin from elsewhere to get what we need. So I don't consider orchiectomy to be a problem going into surgery, but I do recommend that maybe you see the surgeon first and you do get an exam well ahead of surgery so that you know that you're going to be okay, that they feel confident in performing the surgery.
All right. Next question.
Great. Well, this is so exciting.
Oh, here's an interesting question here. Does a former glans piercing have an impact on tissue harvesting for the neoclitoris?
Oh, I love that. Not that I would do it, but to each their own there. But no, fortunately the glans has a tremendous number of nerve endings, and we're actually in the clitorises that we make now, we use more of the glans than we ever had before. So yes, I suppose a piercing might have a bit of scar tissue in the area, but we use most of the glans now, and it's like an iceberg. Some of it's underneath the surface, but the portions that are in the surface, that should still be contactable, and we should be able to still fashion a nice clitoris out of it.
Okay, I have a side question.
Go ahead. But that's kind of the new thing that we're doing. We're trying to create more of a cisgender clitoris, so it has more of a chevron shape, kind of more of a inverted V shape, so that it just looks a little bit more cisgender.
So do you ever run into patients who have had tattoos in the donor site region?
Oh yes, yes. Tattoos are not uncommon. I actually was asked to perform a penectomy for someone who was going to have their penis enshrined in. I don't know if you knew, but there's actually an international penis museum in Reykjavik, Iceland. So I haven't been to Reykjavik yet, but I'm anxious to go. But they have penises allegedly from every species in the world. And this guy was going to be the donor for the human subject. And I'll
Wow,
just
I don't
say,
know if I'm ashamed that I knew about that before you brought it up or not. I don't know what that
did you
says about me, but
did you know?
I've heard about the museum anyway. My gosh.
See, you do read your newspapers, don't you?
I guess. Yes, newspapers. Next question.
Yeah, go ahead. Yes, we do, but they don't provide a big obstacle. Hopefully.
Viewer, a comment here. Wanted to stop by and say hi.
Oh,
Saw you for GRS back in April of 2011. This was put in the chat by Danielle Lynch.
oh, wow, that's so amazing. That's so great to see. Yeah, very nice. Hi, back at you.
Do you hear a lot from former patients? Do people stay in touch with you?
I do. Never enough, of course. Everyone. I think that's the one thing the pandemic has done. It's really slowed me down, and I imagine a lot of people feel that way. I'm sad at how much suffering is going on, but on the other hand, for me personally, it's been a really good time to slow down and just look at just take joy out of the little things. So I have reached out to people I've known and haven't been in communication with for a long time, but I wish I could say hi to every single patient. I really do.
All right. I think that was the end of our questions and answers there. That was quite the grilling, wasn't it? Gosh, I just grilled you for an hour there.
That was pretty intense. You did a great job, though. You're so lovely, and your delivery is just beautiful.
Well, thank you. And thank you so much for an hour of your time this evening. I know that the whole pandemic that the whole world is dealing with right now is, it has a huge impact on a lot of people who are waiting their procedures. But it is an opportunity where I could grab you for an hour tonight, and I do appreciate your time very much. And I'm just overjoyed that we were able to make this work. Thank you so much for being here, Marci.
Fantastic. Yeah, thank you, Samantha. And
all right, well, I should hold on for just a second.
Sure will.
Hold for just a moment here. We'll do our final goodbyes. I do want to take just a moment to talk about next week's episode. Next week,
yes.
We're going to be returning live with our guest, Patricio Manuel. Pat is a professional boxer, and he is the first out trans man to win a professional fight. So we're going to be speaking with him about his journey, challenges, and the current state of transgender individuals in sport. So please join us live a week from today, May 7th, same time, 8 p.m. Eastern, 5 p.m. Pacific. Of course, if you aren't already following us on YouTube, you can subscribe there. You will get live notifications when we do our shows. And our past episodes are also saved there, so you can check those out as well. We're on Facebook at transirl show and Instagram at transirl, so you can follow us and like us there. And as you saw tonight, submit questions that can be answered by our guests. All right, that was the whole spiel there. Let's bring everyone back on here again. Dr. Bowers, thank you again so much for your time and for all the work you do for the entire community. You're really and truly a lifesaver. The work you do saves lives. I know it's had a profound impact on my own, so thank you from the bottom of my heart.
Thank you, Sam. And thank you, Stephen. Thank you for hosting me. Thank you for being patient for me getting on last minute.
It was a pleasure.
Have a great Thanks a lot.
Thanks. Thank you. All right. See you next time, everyone. Bye-bye.